All right, great. I want to say thank you to all of our speakers. We're going to move into the next part of this, which is our after the grand rounds discussion, which is an opportunity to spend another 15 or 20 minutes with our group of excellent speakers, address some of the questions we didn't get to in the larger group setting, and make sure that there's time for conversation. So I want to start by saying thank you to everybody. That was incredibly engaging, really warm, really welcoming to this idea that I think is not familiar to internal medicine doctors as much as it is to psychiatrists and psychologists. So very much appreciate your time. I wanted to start with a couple of practical questions. And I think the most practical one has to do with, there's so many resources out there. How do we know where to go for the thing that we need in that moment?
In that moment?
Given the temporal nature of change and all of that, and intra needs and interpersonal, intrapersonal. How do people know, where to turn, which email to look for, how to search out the resource that they need?
Well, interestingly, that's part of the climate survey that went around when I first got here as chair, and I was looking at one of those questions that if I'm feeling stressed or depressed, do I, how many people actually said that they knew yes or no where to go to get help? And when the Department of Psychiatry, basically like 45% or something, said that they didn't know, I was like, oh my God, we're in so much trouble on this campus, because truthfully, I mean, we actually, more of us did know than people in other departments. And so that really concerned me and brought up the issue of, well, where do people get their information about what to do? And I think one thing that Brooke said, and people can do this without going to the web, if you're starting to feel really anxious, you can stop and take a deep breath. If you need to go someplace that you can actually remove your mask and catch a deep breath, spend a couple of minutes finding a place to be mindful and breathe deeply. That's something you can do without like having to search for a source. Now, there are multiple places where people can actually get other levels of support. So there's like the phone lines, there's, our support groups, there's formal mental health assessment. It's one of the reasons that we created that COVID website, because we knew that people were going to be looking for, what do I need? I just need some advice on how to handle my crazy kids right now, because I am feeling like I'm going to throttle somebody. So we put things like that on the website. So there's a little section that says for parents, healthcare providers, what is it that you're looking for? So I think that that's one place to go. I know that UCH also has the source, and they have links there that people can go to. They've also started virtual behavioral health, where you could actually call and speak to a therapist, usually a licensed clinical social worker. And then if you need something more formal, they refer that individual to us in the department. So there are a lot of places to go to get information, but I would just say focus on that website, that one website, that there's plenty there. Chip, you probably have a lot on your website as well, as if people want to go and look at your programs.
Yeah, I think the Grit website offers some for people there too. So there's probably some overlap with yours. But also the myresiliencehelp.com is a more direct kind of skill building site. That's an interactive website. It's not just information, it's basically a skill building site. So that could be one that if somebody's sitting at home and they don't really want to talk to a therapist and they just want to work on some self-care and improve their capacity to manage all this, that's easy, and it's 24/7. So that's another resource.
Jeff, one of the problems is there's a wealth, right? It's good news and the bad news. And what I really tell people is, we have a great website, use it, but if you have one you like, just stick to it. Don't go surfing for better or different information. Stick to the one that you've felt comfortable with, and stay there, because you can drive yourself absolutely nuts to find the best. And back to the perfect is the enemy of the good, kind of.
And for those who are grieving, families who are grieving, also, I love that phrase, the digital front door, that these websites are an easy place to come to get some of that initial information, written resources, and to learn more about how to connect for support from individuals. And I I mentioned we have care coordinators. I know there are care coordinators throughout different systems within the university and the healthcare system, but finding a care coordinator or somebody who is able to actually talk to you and walk you through it can help any of us not go through a bunch of wrong doors, digital or otherwise, so that we can more readily access those services that are the right fit. There's only so much we can figure out online, and connecting with a real person who can guide us is so key. I know Neil has heard me talk about this in our behavioral health task force meetings around how, what does our state need more of? I think we need more care coordination. We need more people who are helping people get to that right door more quickly.
That's great. Thank you. And those are all excellent resources. And we'll make sure that we post all those with this conversation as well afterwards so people can find them easily. Dr. Burnett, maybe this question will start with you and it can go anywhere after that. But on the other side of the coin, what about people who want to help? What about those who want to get grit trained or want to work in this sphere and are home with time and looking for ways to contribute?
Well, that's an easy one in terms of the GRIT program. Because now that it's been automated, anybody who wants to become a coach that allows them to gain some skills and be able to go out and check in on loved ones and others in their sphere, it's easy. You just go to the GRIT website, grit.uccs.edu, and sign up. And once you've signed up, you get access to 5 hours of content that is interactive content. So it's not just kind of droning through slide after slide. Hopefully not too much of that anyway. And it's I think really useful information for all of us, actually. For those who aren't familiar with disaster recovery and response, I think it could be very helpful for people. So there's a paper I recommend people read called Thriving with a Social Purpose. And it's by a Dr. Martin Ford, who was my mentor at Stanford. And it's a fantastic paper around motivation and how people are able to function at the highest levels. And social purpose is a key component to that. And I think your question is a great one, that if people do have time on their hands a little bit and they want to help, I know and you guys in psychiatry and others, we all are helping people. That's what we do. But recently I've had the chance to actually support some people who really needed an hour's worth of sort of a session, basically, of some professionals. And it was super, I left that feeling so like such a deeper sense of meaning in my life in particular, that I was able to be there for that individual. So it's a huge value, I think, if people can do that.
Mm-hmm.
And for any of our other panelists, anywhere that people should go that you know of or come to you with offers of support?
Sure. I think it depends on, if they want to do something more along the lines of the GRIT training versus, we are trying to reach out across the state to provide things like doc-to-doc consultations. Again, trying to understand why physicians are the least likely to be using our services right now. And again, maybe it's just that they feel like they need to hold it together to support their team, that they're the leader. And we're really trying to figure out ways to help people that are in leadership to also recognize that you could really often use support as well. And your mental health and well-being is just as important as anybody that you're trying to support. So we will be hopefully getting more physicians from across the state contacting us. And I don't know if there's any, internists are probably not wanting to provide that kind of care. But, the medical students that are rotating through internal medicine, the residents and trainees, if they really have time on their hands, our support lines have been really a good place for them to be able to feel like that they're contributing. Because people are calling and sometimes they want advice about mental health issues or emotional issues. Other times they're just kind of saying, hey, this really stinks, and, is there a support group to be in, that kind of thing. So I think that's one thing that they can do with us. And then it sounds like, Chip, you would have opportunities with the GRIT training.
Yes, we're developing a GRIT ambassador program. Mm-hmm. to try to think about that in terms of leadership, people in leadership positions and in other settings.
Mhm.
You know, the findings you're having with physicians is pretty consistent with the literature on physician burnout, and that they just don't seek out resources, and they end up suffering, and then basically, you know, they leave, they drop out of things. And so it's really hard to reach that population. But I think what you're doing there is really vital. And I think you're looking for ways to connect in. So that's important. But yeah, I think there's opportunities in the GRIT system to do that.
Mhm.
And then just in general, volunteering is good for folks getting,
Yeah.
I mean, I know, again, these are a lot of helping folks who are already giving so much of their life to helping people, but sometimes volunteering in a different setting, you know, we have a lot of physicians and counselors who come and volunteer at Judy's House. They want to serve dinner to the families who are grieving because they want to do that very concrete thing of helping our families navigate this time, or, you know, work in the yard. You know, that sometimes it just feels really good to get out of our usual way of helping and to volunteer in other ways.
Mhm.
Yeah, I think we felt that in our program as well. It's one thing for me to put somebody, take them from an elective onto a COVID service, and then they're helping with COVID. It's a whole other when they do it on their own, and it's not, you know, being dictated from above.
Mhm.
For sure. Getting at the idea, a couple you mentioned the same concept of not everyone goes to get help. What do we do with that population who doesn't think they need help, is not going to reach out on their own? Obviously, we try to prompt and we try to offer and we try to lower barriers. But is there a group that just doesn't need help, or does everybody need something and we should really be pushing even harder?
Well, everybody needs something. And, you know, so again, you know, I think healthcare providers are, you know, when we look at things that they all feel that they have a sense of efficacy right now, right? They're doing something important, and that goes a long way. So, and also there is, you know, a sense of community, particularly if you're, you know, working in the hospital. So, you know, I think not everybody needs, you know, official or you know, professional help. Just being able to, again, be intentional about getting support and figuring out the best way to do that is enough for many people. It's the people, you know, it's the people who, you know, are burnt out or struggling, who you know, are irritable. You know, this is where leadership is really key. You know, and for somebody who is the, you know, the unit director or the medical director, say, look, bud, you may not recognize this, but everybody else does. We need to figure out how to help you deal with this.
Mhm.
And again, not in the you know, confrontative way, but just very much, you know, here's what we're seeing, and, you know, we understand it. It's typical reactions to some really crazy times.
Mhm.
I agree with you, Steve, that the leadership aspect, and whether you're a supervisor or an administrator, not being afraid to ask, you know, and not being shy about, I'm really concerned, and you know, slipping them the information, or right up front, you know, talking with them honestly about it. I think some of us need to be hit over the head before we will really take that step for asking for help, whatever that help is.
Mm-hmm.
Well, I think that's one of the reasons that some of the nurse managers for different services at UCH and Highlands Ranch have kind of been taking that leadership role of saying, I know that my folks aren't going to do this on their own. If I need it, I know that probably I'm going to make an assumption that most everybody else does as well. And they've done a great job. I mean, and they've been proactive. They've been reaching out and getting these things scheduled. And so, and I always kind of wonder, so why is it that it seems like the nursing staff is real, and the nurse leadership is really good at doing that? Is there something about disciplines? I don't know if it's because more nurse leaders happen to be female, and Steve's shaking his head. So again, there's one of our gender differences that, you know, yes, females are known to tend to befriend, you know, and sort of be more willing to process at an emotional level. But it's not like we have a dearth of female physicians at UCH and Highlands Ranch or throughout the system. We have a lot. And and even there, they're not. So it's seeking the same kind of opportunities to process. So it does make me wonder if it's more of a discipline issue, that physicians or either people who go into medicine are a certain type of person, temperament, when it comes to how they manage stress, or if there's something about our medical training that kind of knocks out that whatever we had that was a little bit more sort of interpersonal and relational, and we just aren't taking advantage of these opportunities. So I do worry that it has something more to do with the profession, and less about gender biases. Still trying to figure it out, but how do we, because it's not that I don't think that physicians, because if you look at all the burnout data, physicians have a lot of burnout as well. I mean, it's not that nursing staff are more likely to be burnout than physicians are. Suicide rates, for example, in some physician groups is pretty high, or at least high compared to the general population. Alcohol issues are also high, and I think there some data from the China study that that was what frontline physicians were more likely to be having increased alcohol use.
Yeah.
So some of the strategies that we use to cope may be less along the lines of tend and befriend, and I worry about those coping strategies. So we'll see. I like I said, we're doing our best, our level best, to reach out to all disciplines.
That's great. Thank you. The next question, I think, comes from a primary care provider, and I think we can start with Dr. Greasy, if you don't mind, which is this idea that grief occurs along a continuum and that everyone grieves in their own way. But how does a doctor know when to reach out to help someone, to say that this is moving beyond a traditional grief structure and I want to help them move forward or in a different path?
Oh gosh, how many hours do you have? No, it's a really important question, and one that our field of bereavement grapples with, because it is so unique, as I said, and it looks so different for different people. And it comes down to being a personal sense of whether they are at a place where they need support, quite frankly. I mean, I think we can see the signs when the complications are getting in the way, when they're not able to take care of themselves or their family, when they're not able to get back to work at a time when they need to be getting back to work or getting back to school. So it's really that disruption of functioning that we look for to make sure that we are helping them get the coping skills and just really addressing it, I think, and looking at what are the complications. You know, if you're seeing trauma symptoms that are getting in the way, they're avoiding reminders because the trauma symptoms are so intense, we need to address the trauma associated with the death or past trauma that's getting in the way for them also. Relationship struggles, guilt, and some of the magical thinking that we engage in as kids and as adults around feeling like it was our responsibility. I do think that's something that I know some providers are feeling guilty of not being able to save more lives right now. So even if it wasn't your one of your close people in your life, that those feelings around that are really important to grapple with in yourself, of feeling kind of stuck in that sense of guilt or responsibility, and feeling like you have more control over than you had. You know, there is in the DSM-5 probably going to be a grief diagnosis in the near future that looks at timelines of how long you're grieving at an intensity that looks more like acute grief. I personally hope that everyone can access care regardless of a diagnosis, whether or not that diagnosis gets into the DSM, because I think it's really important that we're preventive in our services for people who are grieving, that we acknowledge that when they've gone through something hard, like a death, where they're grieving, that they should have access to the support they need. It's why we have cognitive behavioral strategies built in for the whole continuum, that everyone could use some help with coping when they've gone through something that hard.
Yeah, I'll defer to Brooke, but one of the things that comes up in the literature often is people know when they're impaired and it hasn't, and they haven't been able to kind of go back to their baseline. Mm-hmm. And they may avoid doing anything about it, but they tend to know. And if anything, sometimes we see those people who, got to give themselves a little grace. It's okay that you're doing this. But people tend to, after a couple of weeks, they tend to know, which is very interesting, I think. I don't know, Brooke, if you.
And I do think it so depends on the person. I when I try to put myself in the shoes of a parent who's lost a child to suicide, for instance, or any of these really horrific losses, you have to give yourself grace. And there is that the whole stages of grief really kind of threw people off and thinking it had to be very orderly and with a timeline, but it's not that way. It doesn't work that way, like I said. And so just listening to yourself, knowing yourself, and talking to somebody, getting some validation, normalization for what you're experiencing, but also some help for the places where it's really getting in the way for you and in your relationships and in living.
Mm-hmm.
And I'm sorry. One of the things that I think is interesting from a primary care doc perspective on this is, I've worked with primary care docs before that didn't even want to ask about depression at times. Years ago, because they didn't have the resources and time and availability to manage it in some ways, and that's changed over time. But at this time, when the stress load is so high, the intersection between burnout and the grief experience for a patient is an interesting intersection, because grief is one of those things, when I've done grief work, that it's you have to get in there with the person at some level into the pain of the grief if you're going to be supportive. And it's mostly a listening experience a lot. And I think that's tough for, some primary care situations to dig into that much. And so that would be, I think, a challenging question there, as far as the self-awareness of how burned out somebody is and the ability to hold somebody in their grief. Mm-hmm. That's a challenge, I think.
And if we can demystify it a little and help professionals, providers know that just that human response, like I said, of just being there for them and listening, then people would be less likely to avoid it and less likely to, I think you're right, that especially if we only have 15 minutes to see somebody, that you're afraid to get into something that you can't help with. But just knowing that being human and being there and hearing them is such an important step. And then knowing what resources you can connect them with, where they can go that deeper dive into their grief and healing.
Mm-hmm. That's great. Thank you so much. I think we have time for one last question, and it's a leadership question, since each of you are leaders in your fields, and one of you is a department chair. Is, you have to move things along even during a crisis. And I know myself, I used to get 100 or 200 emails a day asking me to do things, and now I get 100 or 200 emails that start with, I know you don't have time for this, but, and they ask you to do something. So how do you manage your troops during this time? How do you keep the ship moving forward, but be respectful of the fact that there is this elephant in the room?
Well, I'll jump in as the department chair. I have the honor and privilege of leading a department that is, has a lot of people with natural leadership talent, and when stress gets high, they go into overdrive and they kick in and roll up their sleeves and just make sure that our training director was there for our residents, fellowship directors, just again, everybody was, it seemed to me that our leaders, we had to go to virtual care within a 24-hour period of time. I was so impressed with the leadership of our clinic directors. I was so impressed with the leadership of our chief residents. 2 minutes, thank you. Sorry. So there's I think, tapping into the natural talents and leadership skills that people in the department already have, and just letting them go with it. And then we did a lot of internal communicating. We have an internal newsletter. I did a lot of communicating. And so as a leader, I demonstrated that I was physically present and that I was active and that we were going to get through this together. Those kinds of emails, I can't tell you how many times I got email responses from people saying, thank you for doing that. That was really helpful. It's been so great to know that you're there. So I think that that's sort of how we've done it. I would imagine other departments have something similar than that that's going on in their departments. But in any case,
Yeah, and the keys are communication and modeling, right? Right.
Yeah.
Model the behaviors that you want to see from.
Yeah, you communicate and you step up as a leader, and that results in other people doing something similar to, and then also you start to see who has the really great leadership skills, who are going to be your generals after this crisis is over.
Yeah.
You know, I also think it's, you know, it's been interesting. I've been checking in with the team every week, and we've been doing a lot of extra communicating. But, you know, we're all fallible, and I've made some missteps, I think, in communication over the last 2 months. And as a leader, I think also being able to be transparent and vulnerable to a certain extent has been really important. And to say, you know, you're right, I missed that. I thought I dealt with it here, but I didn't, and that kind of thing. So everybody's under a crisis, and being able to say, you know, sorry, I missed it. So that's important too, I think, as a leader.
As a leader, and for all of us,
Right.
letting go of perfection right now, I think, is so critical. And as a recovering perfectionist, this is, again, exposure therapy for me.
Yeah, really.
This whole thing.
Me too.
I think that's great. I think that's the perfect place to end, is something for all of us. So, so I really want to thank you, Dr. Griese, Dr. Epperson, Dr. Berkowitz, Dr. Benight. Thank you all for doing our grand rounds and for doing this post show. We really appreciate it.
Thank you.
Thank you.
Thank you.
My pleasure. Thank you.